Dear colleagues, I'm Filippo Crea, Editor-in-Chief of the European Heart Journal. Welcome to our monthly dialogue. The dialogues are Socratic conversations among journal editors, authors, and readers. The dialogues are free and live streamed. And of course, you can ask questions because they are interactive. Of course, do not forget to subscribe to our YouTube channel. And now it is my privilege to ask Lina Badimon, Executive Editor of the European Heart Journal, to start this important dialogue with Professor Valentin Fuster. The title of the dialogue is From Molecular Mechanism to Health Promotion, the perspective of a protagonist, a true protagonist. And now Lina, please, can you introduce Valentin?
Well, it is a pleasure, an honor to introduce Valentin Fuster with a brief bio sketch, because we don't have time for the whole CV, the whole accomplishment of his life. I worked for 15 years directly with Valentin in the US. During those years, I learned lessons for life. I learned from him passion, rigor, and commitment for advancing knowledge. The idea that each person has the power to improve the life and well-being of others. And that, as Lucius Anneo Seneca said, luck is a matter of preparation meeting opportunity. Yeah, it's true. He really taught me this lesson that has helped me a lot. So Valentin Fuster is now director of the Mount Sinai Heart and physician-in-chief of the Mount Sinai Hospital. In addition, Dr. Fuster is the general director of the National Center for Cardiovascular Research, CINIC, in Madrid, Spain. The innumerable positions he has held include those of the president of the American Heart Association and the president of the World Heart Federation. He is a member of the US National Academy of Medicine, where he chaired the committee for the document on the promotion of cardiovascular health worldwide, and presently co-chairs the advisory committee on the role of the United States in global health. He is a member of the European Horizon 2020 Scientific Panel of Health, of the council, is a council member of the US National Heart, Lung, and Blood Institute, and he is president of the training program of the American College of Cardiology. After qualifying in medicine at the University of Barcelona, Valentin Fuster passed some time in Edinburgh to continue his studies afterwards in the USA. He was professor in medicine and cardiovascular diseases at the Mayo School of Medicine in Minnesota, and in 1982 at the Medical School of Mount Sinai Hospital, New York. From 1991 to 1994, he was the Mallinckrodt Professor of Medicine at Harvard Medical School and Chief of Cardiology of the Massachusetts General Hospital in Boston. In 1994, he was named Director of the Cardiovascular Institute at Mount Sinai, a position he has combined since 2012 with that of Physician-in-Chief of the hospital. He was named Editor-in-Chief of the journal Nature Reviews in Cardiology, and recently he is the Editor-in-Chief of the Journal of American College of Cardiology. Dr. Fuster research is unparalleled in areas relating to the causes, prevention, and treatment of cardiovascular disease globally, and spans the full range from hardcore basic science and molecular biology through clinical studies and large-scale multinational trials to population science and global medicine. His scientific contribution worldwide can be summarized by his age index of 205, and he has been named as a representation of this worldwide activity, honoris causa professor in 35 universities. Among his many awards and honors, I want to highlight the one he received in 1996 is the Prince of Asturias Award in Technical and Scientific Research. That is the highest award possible in Spain. And in 2011, he was awarded the Grand Prix Scientifique of the Institute of France. That is considered a most prestigious award in cardiology. Among his many achievements is noteworthy that Dr. Fuster is the only cardiologist that has received the highest award for research from the 3 leading cardiovascular societies in the world. He has the American Heart Association Gold Medal and Research Achievement Award, the American College of Cardiology Living Legend and Life Achievement Award, and the European Society of Cardiology Gold Medal. In addition, in 2014, the King of Spain granted Dr. Fuster the title of Marquis for his outstanding and unceasing research efforts and his educational outreach work. So his CV can be expanded, but I think this is just enough to understand the success of his professional life. And now I'd like to initiate some questions that I think will really help also to have the audience understand what has been the professional life of Dr. Fuster. So your first publication was on heparin, the hemolytic uremic syndrome and platelet factor 4. So were coagulation and platelets the first passion in your professional life, and why?
Well, first of all, thank you very much, Lina, for your kind introduction. And it's a pleasure to be here today and in answering the questions that you have. The first question is about my first paper. Basically, basic science in the 1960s, one of the aspects was histopathology electron microscopy. And this is what I was asked to get involved with. And this was in my second year of medical student in Liverpool, working with Professor Sheehan. And basically, Professor Sheehan, after 3 or 4 days that I worked with him, presented a slide to me, which I saw nothing under the microscope. And he says, you now need electron microscopy. And this was a platelet plot of a patient with myocardial infarction. We are talking about 1963, 64. And I asked him what this had to do with myocardial infarction. And he said, I don't know, but you're going to do the thesis on this in the future. That slide led me to the platelets. And then what happened is the problem with platelets at that time was platelet aggregation was done in vitro with the Borden approach and others. And I decided to start working in vivo with the release of substances from the platelet. And one of the substances was platelet factor 4. And what happened with the hemolytic system or syndrome, excuse me, is that everybody was giving heparin. And we found a biopsy of the kidney that was full of platelets. And actually platelet factor 4 was extremely high. So this was the publication and saying, you are wrong. This is not a fibrin problem. This is a platelet problem. And this is one of the first times that I published about platelet factor 4 and activation of platelets in vivo.
Yeah, it was a good paper because it was the initiation of a long life dedicated at the beginning to thrombosis. And let me ask you about thrombosis. What about the future of antithrombotic treatment in atherothrombosis? Have we reached already the bottom?
I thought 10 years ago, we reached the bottom. Now I realize that we have to be humble. There's so much to be done. First of all, now we are in the bleeding aspect. We are worried about what we are doing. So we are reducing the number of drugs, particularly in the interventional field, with better stents. On the other hand, we are increasing the number of medications in native disease, like the combination of rivaroxaban with aspirin. Then we are beginning to work on factor 11 and factor 12 inhibitors. And on top, it's not all clotting. Maybe we may do mechanically something that doesn't need anticoagulants, like closing the left atrial appendix. So the field, I think, is continuing to be open, even in a stroke and TIAs. From very small amount of aspirin in a TIA, we are now full anticoagulation after a stroke. So I think the field is changing very rapidly. And what I said 10 years ago, I was completely wrong. we have an open field and we have to be humble.
So we have a question from Rihab Bukarep from Quebec. And he's asking on this topic if there is any role of antithrombotics in the prevention of aortic stenosis.
Well, aortic stenosis is a hot field, pathogenetically speaking, because it's like atherosclerotic disease in a way. And now with imaging technology, particularly with MR and CT, we are learning a lot. I'm not sure about antithrombotic agents, but what I see, there is extracellular matrix there, there is the position of cholesterol there, there is a metabolism leading to calcification and so forth. I wouldn't call antithrombotic agents in native aortic valvular disease as a priority today. It may be in the future, but I see other priorities, which is to understand the disease in itself. And I think we will make progress there.
Very good. Yeah, just before we move to another area of your research life, let me ask you about what do you think has been the most important achievement of your work on the area of thrombosis?
I think the use for the first time on a trial of aspirin in heart disease. And this was in saphenous vein grafts. And I think what was interesting of that work is it was an observation in humans by Favaloro, actually, who started the procedure of clotting in the first 10 days after saphenous vein grafts. And I went to the animal model, the dog model. Now I was working experimentally before you joined me. And it was in the dog model that we saw that the grafts were occluded with platelets. And then at that time, aspirin was really a drug of a lot of discussion. We used aspirin in the dog model, it worked. We went into humans. We added dipyridamole at that time. We wanted to attack two pathways. And, you know, we decreased the occlusion of the graft from 16% to 7%. It was a very interesting achievement and also in a long term. So that to me, the movement from the from observation to the experimental model to the use of a pharmacological agent, and then to get into humans in a trial was, I wouldn't like to call accomplishment, but a fulfillment of investigation, I would call it.
Right. Yeah. So all successful stories are studied with disappointments and difficult moments. Is this also true for you after your successful career?
This is an interesting question. My main disappointments, and it's tough to say that, but I say it, has been with industry. In fact, people know I am not an industry person, although we need it and it's essential. It happened when we used two drugs for a particular problem. When one of the drugs didn't work, the industry continued to market the drug. That was number one. Number two, you might remember recombinant hirudin that we developed, the first antithrombin. And it went into trials when we were concerned about bleeding. Rapamycin, I was the principal investigator. Nobody believed on anything. And then when we were ready to show that was decreasing intimal hyperplasia in the pig model, the drug escaped from me, ended up in Brazil, and they used it without me knowing, having any knowledge. And finally, the most recent COVID study I'm doing on anticoagulants. You go to one part of industry and they said, yes, we will help you if you don't use the other anticoagulant. What I'm saying here openly is that we need industry, of course, and we are working on the polypill and many things with industry. But on the other hand, and particularly for the young people, I think it's important to realize that this is not a free trip. And that's, to me, the main disappointments came from that area.
Thank you. I'm going to pass the word to Filippo now. He has some questions also.
Well, Valentin, first, thank you again for your participation to the dialogue. It is really impressive what you managed to achieve in one single life. Really impressive. And coming to the question, we change page. What about primordial prevention? Is, in your opinion, realistic? This is a question asked by Lale Tokogozulu, who is our deputy editor for dyslipidemia, primordial prevention.
What I am amazed about this, Filippo, is that people don't think about it. We develop all of our habits when we are very young. In fact, if you look at your own behavior today, Filippo, you will realize how important was your age 3, 4, 5, or 6. Why we don't infuse in this at this age the concept that health is a priority to these children. I'm sure it will be very different when they are adults, and this is what we are doing now. And I'm involved actually with 50,000 children with this approach right now. So to talk about primordial approach to disease, to me, is critical. Is before the risk factors takes place. That's what primordial means. And so whoever made this question, just congratulate him.
Well, waiting for primordial prevention, ischemic heart disease and cardiovascular disease remain the killer #1, in spite of all the successful stories we know. So what about the residual risk? This is, I think, a topic of interest for all of us. And this is a question asked by Kathleen Sturgeon from Pasadena and by Edward Wire from Minnesota. Of course, we have a global audience. Valentin, please, residual risk, what are your feelings?
Well, it's a misnomer, if I have to tell you, because we are dealing with a heterogeneous disease, clotting, lipid material, inflammation, and therefore you try to attack each of these problems and you say, but still there are events. Well, I have to say, is anybody attacking the risk factors that lead to the problem? In other words, there are behavioral factors, smoking, hypertension, and many other aspects, a poor diet. So when we talk about residual risk, I understand from the pharmacological point of view to try to approach every aspect of this heterogeneous disease. But frankly, I think we are forgetting that the basic problem starts earlier than that. And I think we should be able to talk about residual lack of use of the brain. And that's what we should talk about it. And there is no emphasis on this. And I understand as a scientist, I really am very much into the issue of residual, addressing the different chemical aspects with different pharmacological agents. But I think we are missing something here, Filippo. And this is what I'm saying to you. I don't know, you might have read the paper we have this week in JAC, which is for the first time, the global aspect of cardiovascular disease in the last 30 years, done with NIH and with the Institute of Metrics. And what we found is that, in fact, the #1 problem now is that mortality begins to increase. And if you go there, some people who tell you superficially will say people are aging. And some other people will tell you, well, this is a problem of the recent times and so forth, but is not done properly. Well, first of all, what we have found is the risk factors is the #1 problem today in increasing mortality. It's not the increase in aging in 30 years, and it's not the increase in population. So the question is, how can we now go down in mortality again because it's going up? It's going into the risk factors, and it's going into the education and so forth. So I just wanted to give you a sense that when we talk about residual risk, we are not paying attention to where the problem is, and mortality continues to increase despite of all the pharmacological agents that we have today. This is the problem, Filippo.
Well, Valentin, thank you for this global perspective. But I go more specific also because Peter Lieb is listening to us. What about residual risk and inflammation? Is, in your opinion, inflammation is an important target? This is the question asked by Augusto Gallino.
Inflammation is a very important aspect, and Peter Levy actually is moving from the residual aspect of the chemicals or inflammation also to health. I heard him. First of all, in inflammation, I think there are many pathways. So it's is in itself very heterogeneous. Inflammation you can have on one canakinumab with interleukin-1, interleukin-6, but then you have colchicine, you have methotrexate, you have other cytokines that lead to inflammation, interferon, for example, or tumor necrotic factor. What I'm saying to you is when we talk to residual from the point of view of inflammation alone, there is a lot of residual there because you cannot attack inflammation on a single pathway. And I think this is a clear example that we'll always have some residual at the molecular level, but I just want to emphasize again, there is another residual that we are not paying attention to.
Thank you, Valentin. And now we change page again. The title of this dialogue is The Perspective of Protagonist. And you are a protagonist also when we come to stem cells. What are your views about stem cells? Somebody says this is the treatment for the future and it will always be. Do you think so? You think there's a future for stem cells?
Well, first of all, let me tell you about the field. We are learning a lot. So everybody who says this didn't work in the heart, I say maybe it didn't, but certainly we are learning a lot. What we learned in the last 10 years is incredible. By the induction of pluripotential kind of a stem cell approach, I think this has a, in my view, tremendous future with genetic gene therapy or even with manipulation of microRNAs and so forth. There is a future there. The question is, can you change the heart, if we talk about the heart, in a definitive manner, or is going to be temporal? I don't know about it, but there's two aspects I want to emphasize. First, we didn't pay attention to the connective tissue. Remember that the heart doesn't work because the tremendous extracellular matrix that is there. Can we reverse that? And second, we have a model that is the pig with a heart very similar than humans. Can we make the pig heart close to human? And then getting into the field of transplantation completely differently. So what I'm saying to you is I wouldn't be negative about it. I would say I am positive into what we are learning with all these aspects I'm talking about. Even the, you know, the issue of the vesicles that can be injected and so forth is so fascinating, the whole field, that I can predict that in 10, 15 years, we will have an answer. At this moment, may have been a lot of frustration, but you are learning a lot. So I'm not pessimistic.
So back to Barcelona. I realized that we are in the same parallel, you know, New York, Barcelona, Rome. This is something that we can do nowadays. So let me dwell a little bit more on your latest interest, that is the promotion of health, right? We have to go to promoting health. The WHO has recently changed the definition of health. So health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmities. Do you agree with this definition? How can we achieve it?
I agree completely with the definition. Remember, the mind is involved, the head is involved, as I have been saying here. Okay, let me tell you, I made a huge change in 2006, and I still remember. Basically, I came out from the American Heart Association and from the World Heart Federation with a great experience. But I realized that we were investing a lot in understanding the latest stages of the disease. And we were not investing into what health is all about. In fact, I must say at that time, I realized I knew more about disease than about health in the cardiovascular system. So I decided to move with the same tools that we were using, Lina, and you and I were working together with the same tools that we use for understanding disease to go to understand health. I tried to promote imaging, I tried to promote a number of things, and then I realized one thing that was a great mistake. When we talk about promoting health, we don't distinguish the age of the population we are dealing with. And I realized that to talk about the elderly population, the midlife or early childhood is completely different if we deal with the issue of health. And then, you know, what I decided to do is to develop at least 6 or 7 projects that are now active, which are related to, in the elderly, I'm interested in cognitive function by imaging related to the risk factors. In the midlife, is how to identify disease non-invasively with 3D ultrasound, and people then may change behavior once they realize they have disease. And in children, you know, my investment in actually promoting health with a very prospective approach in a number of trials that we are having. So that's my life at the present time, but the technology that we are using is the same technology that is being used for disease. It's very sophisticated, and I think I'm very excited in moving the pendulum from the end of life to the very beginning.
Very good. So your professional life is extremely intense. That we know. You know the best, but we know. From Europe to the States in several top institutions, and now part-time in Europe and part-time in the US. So what are the best and the worst you have found in the two continents, in America and in Europe?
Oh, this is a tough question, Lina, very tough. Well, first of all, let me go to the institutions. Mayo, I started in Edinburgh, Scotland, in the 1960s. What I learned there, simplicity out of complexity. There were not the funding and the methodologies available. So I learned there basic clinical and basic research in a very non-sophisticated manner, but with a lot of common sense. That was critical in my formation, in my development. Mayo Clinic, fantastic organization. Then we have, from Mayo Clinic, we have actually in Boston, in the Mass General Hospital. I learned the talent of the young people that are there, unbelievable. Then Mount Sinai, the freedom, no much bureaucracy, but really you are free there. And this is fantastic. And you have been there and you know what I'm talking about. And then Madrid, the National Center of Cardiovascular Investigation, a real example of how in a country that actually from the scientific point of view and culturally has not been, I would say, in the frontiers, but how you can motivate young people. So there are differences depending on the institution you are. Now, the question is, there is any gross difference between United States and Europe? Because this is your question. I would say perhaps there is one difference. The support, financial support, and obstacles in Europe are significant, I would say. But the motivation of people under those circumstances is an example, certainly has been to me. I love to see what I see in Europe, sometimes people working in circumstances that I would say, how difficult. I am an admirer. United States is the opposite. Great support, not many obstacles, but there is one problem. And the problem is you are really at high risk. You can produce today. If you don't produce tomorrow, you are in the street. So I would say that it's a very difficult, but all has to do with the support that you have in both parts of the world, but you play the odds depending where you are.
Yeah. So I have a question now coming from Gemma Chiva Blanc from Barcelona. And it's associated to what you were explaining. What are your suggestions to our young colleagues for a successful scientific career? It will depend if they are in Spain, Europe, or in the US, but what is your general message?
Focusing on young people, I would say to you, the first thing to learn is who you are. What is your talent? To try to infuse investigation on somebody who is not creative is a waste of time. And actually, I have a lot to say that there are many people who are pushing and pushing and pushing. They don't have the creativity. So I think first is to discover your talent. If your talent is that of being creative and for investigation, be discovered as quickly as possible, which is what we are doing in CINIC, as you know, in Spain. Is very critical. So the first thing is, do I have the talent for research? Once you have the talent, I would give you 3 messages, and this is what I do to the young people. First, number 1, be creative for the world that you are, not only for yourself, because you are lucky where you are and the talent that you have. It's a matter of responsibility. Be creative, not only in research and publications, could be creative in many aspects. The second thing is, you should be satisfied with your life and be fulfilled. This is quite different than ambition. Is I am doing what I'm supposed to do, and I am doing in the best way I can. And this sense of fulfillment is critical for young people, rather than trying to use something that is not your talent. I am doing what I'm supposed to do. And the third issue, which is the team effort. And that is, if you are not ready to work with other people, is a suicidal approach. So I would say, first, to have the talent to be creative, and then to create for others is an obligation, to be fulfilled for what you do and be happy with it and consistent, and then a team effort. This is what I would say are the rules that I would actually advise to a young person. Not everybody is creative, my friend, you know that. And we see so many frustrations. The first paper that is submitted and is not accepted, they quit and they become frustrated. I think that's not a creative person.
Well, these are good recommendations indeed. What about another aspect now? What about reaching the sky in non-scientific areas, right? We will allow the audience to know you a little bit better. So tell us about your cycling experiences in the steep mountain peaks of the Pyrenees, in the Stelvio, in other mountains in Europe, in the Monteroli, in the Alps. Tell us about that, about your experiences climbing mountains.
Well, it's interesting. I started in the Mont Ventoux in France in a trip with a friend, and I ended up climbing that with bicycle, and I was able to do it, and I became excited about it. Why I became excited? Because it's a combination of nature, natural, you can think. It's a sense of real personal fulfillment. The question is, can I do this more professionally, or let's say more dedicated to? And then I got in touch with the manager of Indurain. Indurain actually was the winner of the Tour de France for 5 times. It was very interesting what he told me. I said, look, I worked in the Mount Ventoux and I liked the nature and so forth. He says, you know, you will make it. Make it. And I said, how can you say that? Because you already asked the question. What he told me is for people to predict they're going to make it is when they ask the question. And I asked the question, and this is very important also in research, to say, I'm going to motivate people, and you start giving talks and they are half asleep. Excuse me. They have to come to you and ask, I want you to be my mentor. I want you to do this. That's the person. And then I started, he gave me just the confidence that I was in the right place. And frankly, yes, I have done already 25 mountains of first category. I do one every year. And now I am in Italy, actually. I did the Stelvios. the Stelvio, Montirolo, and then I'm trying to next year see which one I do. But I think it's very interesting, the motivation. You have to be motivated and passionate about it. And then you can make impossible.
Yeah.
Actually, Indurain told me very recently, I don't believe you climbed the Tourmalet 5 times at your age. And I said, you don't believe it, but I did it. I don't believe it either, but I am motivated for it.
Well, but you know, this love that you have for sports come from early ages. Tell us about your youth as a champion in tennis.
Well, that's in another story. I used to play tennis 3-4 hours a day, and this was my life. I flunked a subject, I don't know which one it was, and my father said, this summer, you are not going to play tennis. And I was supposed to go to the Orange Bowl, which is the Young Davis Cup in Miami. And then I trained for 1 week, and they said, you will not have any problem to go to Miami. And then I played and I lost. And you know what? That day was the last day that I used a racket, certainly for many years. But I decided to do that. What I decided that day is my talent was not tennis. You see, that's the issue we discussed before. You may have an ambition, but maybe you are not set up. And I said, you will be an average tennis player. Why to be an average? You quit, and that's it. And then I had a great person, a physician who played tennis actually in the same Barcelona club, who saw me quite depressed about things. I didn't know what to do. I was, an average student. And he said, you know what? You will be a great doctor. And I said, how can you say that? But he was probably the physician better recognized in Spain. So I trusted him and I became a doctor. Then he got an infarct. I became a cardiologist. This is what he wanted me to do. And then I went to every summer, and the guy who showed me the platelets in the slide, this is what I did, is to work on platelets. The point I'm trying to make that the young people don't understand is the importance of mentorship. And a mentor is somebody who has your chemistry and somebody who would jump into the ocean for you and is somebody you believe. So what I did is to believe what they told me because I trusted them. The issue of mentorship came into all this. Tennis, I was not made for.
Yeah. So, Valentin, let us not forget your humanism. You already told us things that directed us to think on these aspects of your life as a person. I think this is a strong power that you have. You have an intense relation with the intangible values and riches of life. Your family, your beautiful wife, my dearest friend, Maria, and how you engage on these values that are associated to medicine in part and the practicing of medicine, but also that produce riches into a person that are not only the profession and the how many papers you have and how many recognitions you have, is how you feel in your insight regarding the humane values.
What is interesting, if somebody asked this question to me recently, I learned a lot from Judaism. I learned a lot from Buddhism, and I learned a lot from Christianism. And Maimonides, for example, on the Judaism, told me the interaction between science, medicine, and ethics, and had a tremendous impact on me, just Maimonides. Then, if we go to Judaism, the issue also of creativity is very important, and then we have very critical. You said you're a very positive person, Lina. I am very positive too. Our life has meaningfulness. We are thankful. This is Buddhism. It had an incredible impact on me too. And then we have the Christianism that is to give to the other. So when you're asking where I'm coming from, I read a lot about all these different religions. And I must say to you, I'm talking about age 14, 15, 16, 17. They had a tremendous impact on me. I think that's the way I developed. And I think it's just to get the virtues of each of these, I think had a significant impact.
Indeed, these are values we need to keep because the world is in a waving situation and we need to have really strong values. So back to you, Filippo.
Well, Valentin, you are a protagonist not only as tennis player, but also as editor-in-chief of Jack. What is the mission of an editor-in-chief?
I think I already mentioned to Lina the virtues that I think we carry with ourselves as obligatory. First of all, I would say to you, I mentioned I mentioned ethics, I think in science, and I mentioned Maimonides. I think this is essential for the editor of a journal. We have to tell the truth, and we are dealing with medicine and we are dealing with science. Then we have to be very creative. And that is, we are editors of a journal, not to move papers from Monday to Saturday and to talk to the same people all the time. It's what we create there. The science is changing, we should change. So I think creativity is another aspect that is already mentioned when I talk about you know, the virtues. And the third one is quite important, and this is one I want to emphasize. Who are we going after? We are educating people in a way, indirectly. We are providing science. We are contributing to science. And that is, what is the impact? And a final comment is about impact factor. There is an obsession in the journals about impact factor. This is the way I see it. Be sure you are not out. You have to be in the game. But I think the impact is, who are we reaching? Are we having an impact? Remember, the impact factor depends on investigators who read the journals and publish in the journals. But 80% of the people do not publish in the journals, but they read the journals. And my question is, as an editor, I am very, very much sensitized to the impact that we may have on the reader, not only on the investigator. So I think these are the aspects that I think we, as responsible of journals, should be.
Well, Valentin, thank you for your inspiring words. And this is indeed a wonderful dialogue spanning from science to philosophy and to religion. And I have one last question for you. What are your suggestions for the EHJ dialogues like today?
First of all, I feel frankly very humble here talking to you. Thank you. But I feel we are a little piece on a whole motor engine here, which is maybe called science, medicine, etc. So I feel very humble, and I think what I would suggest to you is that get into the motor engine, and that is, why don't begin to interview a number of people who pioneer a field. For example, ablation, or for example, what is going on with the structural heart disease, what is going on with dissection of the aorta we did with the group at Stanford, how it has evolved over the years, and you have a number of people. So I would probably, at least I would say to you that this would be quite important, particularly for the young people, to understand the history of a field rather than an individual, because frankly, we are very little in the whole process. Although many times we try to believe that we are somebody, but this is basically what it is. So I would take that approach.
Well, Valentin, thank you for your inspiring words and for these suggestions. And this concludes our dialogue. I would love to give you and Lina a big hug. It is virtual, but it's very sincere. It's been a wonderful hour. And this is the last dialogue of this year. We know that it has been a difficult year, but it is in difficult moments that humankind provides its best performances, and this will be no exception. I'm sure that teamwork and confidence in science will allow us to overcome this difficult moment, and I'm sure that we will have a happy new year with vaccines which are on the way. And this is, of course, I take this opportunity to wish all of you with Lina and Valentin a very happy new year. And please do not forget that we will have a dialogue. In the first dialogue will be the last Thursday in January, will be Thursday 28th at 17 Central European time. So we close with a wonderful dialogue, and we are already ready for the next dialogue, the first next year. Thank you for your participation and attention. Bye-bye.
Thank you.
Thank you
Goodbye.
very much. Bye-bye.
Bye-bye.
Thanks to you. Thanks.
Bye.